My name is Melanie Dizon. I'm the Director of Education and Research at the Davis Phinney Foundation, and I am here today with Roseanne Dobkin. Hello, Roseanne. How are you?
Hey, Mel, I'm great. Thank you so much for asking me to join the group this afternoon.
Yeah, we're so glad to have you. We're going to be talking. Yes, everything will be recorded. Everything. This whole session is going to be recorded. We are going to be talking about mood, managing mood and anxiety in Parkinson's. And I'm going to tell you a little bit more about Roseanne. Read her bio. You can also get information from her on our website because Roseanne is actually part of our Science Advisory Board. And we are busy right now because we are in the midst of reviewing applications for this grant round. So it's busy time here. Dr. Roseanne Dobkin is a licensed psychologist with a well-established clinical research program in Parkinson's mental health. The overarching goal of her research program is to help people with Parkinson's and their family members cope as effectively as possible with various challenges in order to enhance overall physical and emotional health and quality of life. Her research and clinical work over the past 15 years has focused on the development and testing of non-pharmacological management approaches for the cognitive and psychiatric complications of Parkinson's, such as depression and anxiety. She has also systematically explored the interactions between physical and mental health in Parkinson's and the impact of their intricate associations on quality of life and functional disability. Moreover, she has begun to systematically examine barriers to mental health care utilization in Parkinson's, the use of telemedicine. You may have seen her on our webinar earlier this year that we did on telemedicine, to leverage access to specialized mental health care in Parkinson's and the impact of successful depression treatment on key outcomes such as cognition, physical disability, quality of life, and caregiver health. So we have so much to talk about today. We're going to get right into it. First, I want to just talk about mood in general. So what do people mean when they talk about mood? And what's the difference between sort of that general comment of being in a bad mood versus having a mood disorder?
Oh, so great question. And this is a topic that I am so, incredibly passionate about. So I just have to say once again that I'm thrilled to be here today. And I see the number of participants rising on the screen and all the comments, coming into the chat box from people all over the country. So that's just so exciting for me. But so going back to the question about mood. So when we say mood is a very catch-all phrase. It's a very complex term. So mood can encompass things like our emotions. So how we're feeling, if we're feeling sad, if we're feeling lonely, if we're feeling demoralized or anxious or angry. Mood can also really encompass sort of our behaviors because we may act in a certain way that's in accordance with our emotions. So if we are withdrawn, if we are avoiding, people, places, and things, that can be reflective of the type of mood we're in. If we kind of just don't have that zest and that enthusiasm, to go to the football game that we used to love to go to, or to play with our grandkids, or to return a phone call to a close friend, that's part of our mood. And our mood also can speak to our thoughts, how we're thinking about things and the meaning and the interpretation, the value that we're finding day in and day out. So mood is pretty complicated, and it can really encompass emotions. It can encompass our behaviors, what we're doing and not doing, as well as, how we're thinking about things. And, nobody has a mood that's a flat line. We all experience a range of emotions all the time. And that means we are living, breathing, feeling, sensing human beings, and we want to feel emotions. So if we experience a loss, for example, if a loved one were to pass away, it's expected to feel sad and to feel down for a period of time. We certainly don't want to, pathologize normal emotions, but it's when these negative emotions persist, when they are above and beyond what might be reasonably expected given the life circumstances that somebody is facing, when these feelings begin to get in our way, slow us down, make life harder, when they cause us tremendous distress, that's when it becomes a much bigger problem.
Goodness, I did it. I did the mute thing. Okay. So you mentioned the reasonable expectation, like the reasonable level that a mood persists. Let's say it's deep sadness or a depression. Maybe, you might categorize it as situational, right? You got diagnosed. here's the question I have that a lot of people ask. So they notice depression, like in hindsight, right? They look back and they say, oh, I had that for a long time. That's often a premotor sign of Parkinson's. Yep. But like, now they look at it and they say, what is a reasonable expectation of being in this place after diagnosis, right? I mean, when does it get to be not working for you anymore? And you say, wow, I need some real professional help. Or is it expected with Parkinson's to have a sort of low level of, depression and sadness?
Mm-hmm. So that's a really important question. I think there are actually a couple of different questions that maybe are embedded in that first question. So let me try to break it down a bit. And if I leave an important piece out, remind me that I left that important piece out. So certainly, being diagnosed with Parkinson's is a major life stressor. And there are challenges and understandable emotional reactions that people face, at the time of diagnosis, as well as, at various stages on the journey living with Parkinson's, as symptoms change, as reactions to medications change, as kids get older, as you retire from work, potentially as some, may pursue disability. So there's lots of changes and stages along the way. And each change from the time of diagnosis to adjustment to new changes and challenges that Parkinson's presents can understandably be associated with feelings of sadness or anxiety or apprehension or frustration. And it's okay to sit with those feelings and to figure out how you feel about the diagnosis, about the changes, to talk to your supports and find ways of coping to help alleviate some of that emotional distress. But when those symptoms persist and they're present most of the day, nearly every day, for weeks at a time. And it's really difficult to do anything to get those symptoms to abate, to get those symptoms under control. That's when it becomes important to reach out, not just to friends and family, but to a trained mental health professional. It's when the symptoms are pervasive, when they're there most of the day, nearly every day for an extended period of time, and they're having a clear and lasting impact on your social life, on your important relationships, and on your ability to engage with your day, to volunteer or to continue to work in your job. When that functional impairment is significantly increased because of your mood, that's when we really need to reach out and to seek help. And to your earlier point, Mel, depression and anxiety, a lot of these mood symptoms, they are part of Parkinson's. It's not like people, okay, you've got this diagnosis of a movement disorder, and then in addition, you're experiencing some depression or some anxiety or some insomnia. Those are all important non-motor features of Parkinson's. So when people think about Parkinson's, sometimes, and inaccurately so, they think Parkinson's, okay, it's just a movement disorder. It's all about, tremor or being stiff or being slower. And yes, it is about all of those things, but it's just as much about sometimes feeling sad or feeling anxious, feeling unsure of yourself in social situations. And when we can identify and we can treat those non-motor features that are associated with PD, we can improve all aspects of quality of life and really enhance, every single component of PD care.
Yeah. So a lot of times people will ask, am I depressed because of Parkinson's? Or am I just depressed and also have Parkinson's? So I want to talk a little bit about that, and we'll talk about treatments a little bit, but I'm curious. So as somebody who's maybe caring for somebody who's been diagnosed, some people will describe a situation where they get diagnosed and that person sort of goes into denial. And is that often related to it's like a behavior of depression? Is like, what is that? And how do people that are caring for somebody like that help? Because not dealing with it is not helpful, but they also are like, they might be flitting around and pretending like nothing's wrong and they're just denying it all. So what do you do in that situation?
Mm-hmm. So the first thing I have to say is everybody copes in very different ways, and there is not one right response. We tend to think about, healthy coping versus, less healthy coping. So certainly, in the short run, maybe for a couple of days, a couple of weeks, maybe a month or so, maybe denial is adaptive. It gives the person some time to kind of adjust and to process and to figure out a path forward. But when something like denial persists and it maybe prevents people from, joining Rocksteady boxing or pursuing other aspects of PD related care that we know are incredibly beneficial, that's when it becomes problematic. And I think a lot of the differences that we see with respect to coping ability, right? You have some people, the minute they walk out of that appointment, yeah, they're disappointed and, that they were wishing that that was not the news that they received, but they leave the movement disorder specialist's office with a stack of literature and they're on the phone and they're calling PT and they're calling speech, even if they feel like they don't quite need it yet, just because they want to build their skill set. And they're calling the support group and they're going to Rocksteady. So they're taking a very different, more empowered, more proactive approach that's going to lead to a very different, most definitely more optimal outcome. Whereas other folks who maybe think, oh, well, this isn't real, or there's nothing I can do, this is a lost cause, why try? They're not going to follow up with all of those referrals. They're not going to learn from other people that have been living well with Parkinson's and have an awful lot to share about how they can now learn to live well with Parkinson's. So a lot of it comes back to our mindset and our thoughts. So when I was speaking earlier about the fact that mood is like this very complex, multifaceted phenomenon, the interpretation of what's happening, what the diagnosis means, an individual's ability to deal with it and find a healthy, positive path forward, that mindset can make all the difference in the world with respect to an individual's coping response. Because if somebody leaves that initial appointment and says to themselves, you know what, this is really tough, but I'm going to have a good life starting today, independent of this diagnosis, they're going to be much more proactive in their self-care. If an individual doesn't come to terms with the fact that they have to deal with this medical condition, or they tell themselves, well, there's nothing I can do to make things better, so why try, then their outcome is going to look very, very different. So the mindset, the interpretation of what it means to live with Parkinson's, as well as an individual's ability to cope proactively and find meaning and find value, makes huge difference, because everybody can live an amazing life. But a lot of it depends on how an individual is thinking about themselves, thinking about their situation, and their ability to realistically appraise the strengths and the resources that they have to push forward and fight.
Great. So let's go dive a little deep into two of the things that we often talk about when we talk about mood. So we're talking about depression and anxiety. Can you talk about what are they? How are they different? Do they often come together? Are they very frequently just one or the other? And yeah, just give us a debrief for
that great question. And that's actually a question that I answer for people, very frequently in my office. So I'm really happy that I have the opportunity to kind of share some of this information to so many on the webinar today. So depression and anxiety they're both negative emotions, negative feelings, though at times both could be very appropriate to the circumstances that we're facing and that we're dealing with. They can occur separately, but they frequently co-occur. In terms of what distinguishes them, when we're talking about depression, we're talking usually about feelings of sadness, feelings as if your mood's not as good as you'd like it to be, decreased interest in activities that you once enjoyed, not having that zest and that enthusiasm to go and do and experience. Depression can also be associated with lots of feelings of helplessness, hopelessness, changes in sleep and appetite, feeling that life lacks meaning or purpose, feeling very worthless or fatigued, and in more serious cases, feeling that life is not worth living or actually having thoughts about harming oneself. And, I will just say, if anybody's having thoughts of self-harm, or thinking that life is not worth living, that's a red flag to immediately reach out to a family member as well as to a professional in order to talk through those feelings. So that characterizes depression. So whereas depression is more defined by sadness, anxiety is more defined by worry. So worrying about daily things, maybe above and beyond what would be dictated by the situation. Anxiety can also be characterized by what I call, what if thinking. What if I drop the letter on the way to the mailbox? What if I forgot to put the stamp on? What if I run out of milk before the end of the week and I have to go to the grocery store again? So a lot of excessive worry about everyday things, a lot of what ifing. Anxiety can also be characterized by additional feelings of physical tension and restlessness, above and beyond what Parkinson's itself may create. It can be a fear about a specific place or situation. Oftentimes, people with Parkinson's will share with me they're very fearful of having physical symptoms, of tremor or dyskinesia, let's say, in public. Sometimes the fear might be of speaking in public, or it could be a fear that isn't so much Parkinson's related, but it's occurring in the context of Parkinson's. So fear of traveling or flying. So it can be an intense fear about a specific event or person or place. Oftentimes, anxiety can also manifest with a lot of what we call physical symptoms. An individual's heart's racing. They may feel short of breath. They may feel very sweaty. They may start to experience internal sensations of panic. And the other big criteria that we see with anxiety is avoidance. People, they opt out of life. They stop doing, they stop engaging. They say no when they could otherwise say yes.
Okay. That made me think, how is that side of apathy? Is it related, of anxiety? Is it related to apathy? It's because it's the sort of that opting out, but is apathy the same thing?
So apathy is related, but it's actually its own unique construct. So when we think about like the non-motor or the neuropsychiatric aspects of PD, depression, anxiety, and apathy would all fall under that umbrella, but they are different emotional experiences. And the best way I can explain it is if somebody is anxious, and because they're anxious, they are not engaging in a certain activity. Let's say that they decline the picnic. They're not going to go to the family picnic because they're anxious. It's because they're scared. It's because they're afraid. So it's that fear that is keeping them from going and engaging and doing. Whereas if they're apathetic, there's no fear, but it's almost the absence of emotion. So it's not that they don't want to go because they're too scared to go. It's not that they don't want to go because, maybe they're just feeling so sad and, they don't see the point because they fear that they will not enjoy themselves, but it's more that they feel very little.
They just don't care.
They just don't care.
They don't have a feeling about it.
I mean, that's an oversimplification,
right?
But it's really like feeling sad versus feeling scared versus not feeling.
Yeah. So let's talk a little bit about the pharmacological and non-pharmacological ways of treating depression and anxiety. What, first of all, is the biggest challenge for people with Parkinson's who experience depression and anxiety? What is so difficult about maybe diagnosing this or treating it alongside all of their also, motor symptoms?
Mm-hmm. So I'm going to get on my soapbox for a moment here. So that, I think your question, like, again, hits the nail on the head. I think one of the biggest challenges is that despite the fact that anxiety and depression are so common and they affect the overwhelming majority of people with Parkinson's disease, more so than the average person without Parkinson's disease, of the same age, these conditions are underdiagnosed and they are suboptimally treated. So in my opinion, that's one of the biggest challenges is as a Parkinson's community, as healthcare professionals, working with people with Parkinson's and their family members, we have to do a better job recognizing and detecting the presence of the depression, the presence of the anxiety, so that appropriate treatment recommendations can be made. And this goes back to something that we were speaking about earlier. Oftentimes, these non-motor symptoms will present themselves decades before the onset of the motor symptoms or the physical symptoms of Parkinson's. And so what ends up happening is that even though these symptoms are uncomfortable, people kind of get used to it and they're not really experienced as something that's new or different. It's kind of, it becomes the person's baseline. So they're visiting with their neurologist or with their family doctor, and oftentimes the doctor will ask, "Oh, has anything changed? Any new symptoms since we last got together?" And it's not a new symptom, so it doesn't get reported because people get used to it. But trust me when I tell you, we can do better than just getting by. So if you don't like how you're feeling, even if it's something that you have been feeling for years, it's still so important to speak up and let somebody know, because there are effective treatments out there. So that's the biggest challenge, is that I think healthcare professionals need to do a better job recognizing depression and anxiety, not just simply discounting it as par for the course, because yes, these are common features of Parkinson's, but they are treatable features of Parkinson's. If you went to the movement disorder specialist and you said, "Oh, I think, we need to take a closer look at my tremor because it's really impacting my daily functioning." Well, of course, that tremor is going to be looked at quite closely so that medication adjustments can be made. Same thing goes for depression or anxiety. We have to focus on treating those symptoms just as much as we focus on treating, balance or tremor, or making recommendations related to walking. So that's a really big challenge. And I cannot overstate that even if these symptoms have been, in play for you for quite some time, now is the time to speak up, because our effective treatments are available. There's no reason to suffer in silence. If we can improve depression and anxiety, we can improve all aspects of living with Parkinson's disease.
Right.
So I know there were other questions, Mel, that were like embedded in that question.
Yeah.
So reorient me.
I will get back to that. I just want to speak to this piece. So, with your experience working with movement disorder specialists and, having that cross-functional team piece, is it something that you think is starting there? It's the movement disorder specialists or the neurologists that are asking a question in a way that's not getting to the heart of it. And it would be better for them do they proactively ask about things like quick screenings regarding depression and anxiety that would have those issues come out, more than saying, did something change? Is that
so it's everybody's job to screen and to assess and to intervene as appropriate. And I think there's a lot of variation in terms of what happens, across doctors' offices. So there are some movement disorder specialists, many that will ask each and every time and do a systematic screen for depression and anxiety and other neuropsychiatric complications, using a standardized interview or a self-report questionnaire that the individual fills out, every single time they go into the office in order to track changes in depression or anxiety and sleep. And then I'll be honest, there's some other doctors that probably don't mention it at all. So I think it really varies practice to practice and center to center, which is why I think everybody in the Parkinson's community has to assume some ownership here. People living with PD, we were talking a little bit about family members earlier. Sometimes the spouse or the child or the close friend will notice a change in their loved one. And it's okay to bring that to the attention of the movement disorder specialist during that appointment. Or I get calls, and I'm so happy to say this, from physical therapists or speech therapists that I know, because the neurologist didn't pick up on it, but the speech therapist did, and makes the referral. So I think it's the job of everybody who is part of the multidisciplinary team to be on the lookout for red flags or warning signs that maybe mood is not as good as it could be and that there's room for improvement.
Yeah. And I think it's really important for everyone on the call, whether you're a care partner or you are somebody living with Parkinson's, that you bring it up. If your doctor's not bringing it up, bring it up, because the reality is the downstream impacts of being able to have treatment for depression and anxiety are huge. So if you are experiencing really bad motor symptoms, but your depression or anxiety is preventing you from exercising, let's say, well, then it's just going to be a cycle that's going to continue to get worse. But if you can treat and then your motor symptoms are also going to be worse. But if you treat the anxiety or depression and you get that under control, what makes you have more initiative in your life, and you want to work out, then you will not only help with that piece, but you will also help with the motor. So it is super important to be an advocate for that. Can we talk?
That's a great point. And actually, I just want to highlight and underscore that for another moment or two. That is actually what often will tip off, let's say, the speech therapist or the physical therapist or the support group leader. If somebody's kind of stuck in the mud and they can't get going and they can't follow through, or maybe the care partner notices, well, they have all these exercises they can do, but they're not, setting up a schedule, they're not practicing. If you can't move forward with your goals, if you can't engage in the behaviors that are important to you and are very much aligned with your personal values and aspirations, that's a really big red flag that we need to take a closer look at depression and at anxiety.
Great, thanks. Let's talk about treatments. Let's talk about depression first. What are some of the common treatments, pharmacological and non-pharmacological, for depression that you see in your practice?
Sure. So as far as treatment is concerned, we usually think about antidepressants and or psychotherapy, talk therapy, being first line interventions. And if an individual were to start treatment with a medication or with psychotherapy or with both, very much depends on kind of the nature and the severity of the symptom presentation, as well as preference. There are some people that just prefer to do talk therapy, which is wonderful, and others that would just prefer to take a medication, which is perfectly fine as well. So as far as medications go, there are different classes of antidepressants that are out there and available. And I get this question a lot, like, what's the one best antidepressant for people who are living with Parkinson's? There isn't one best antidepressant. I think a very open and honest conversation with your doctor about the types of symptoms that you are experiencing, because just like Parkinson's is different person to person, depression in Parkinson's is different person to person. So sometimes people may be sleeping a lot and overeating, whereas other times if they're depressed, they may be hardly sleeping at all and they've lost 20 pounds in 2 months, even though they're not trying. So a doctor can sometimes select the right antidepressant in order to best target the specific types of depressive symptoms that each unique individual is having. Because certain types of antidepressants are better, let's say if you're sleeping a lot versus sleeping a little, or if you have very low energy, et cetera. So matching the selection of the drug to individual history, maybe what's worked for other family members, what has worked or not worked for that particular person in the past, as well as with sort of key consideration for active symptoms of depression that are currently at play. So some of the common classes, we have the SSRIs or SNRIs, which would include things like Prozac, Zoloft, Lexapro, Effexor, Cymbalta. These may be medications that you've heard. Sometimes in Parkinson's, they even use an older class of antidepressant medications called tricyclics, which includes a drug called nortriptyline, which has actually been studied systematically in PD depression and has found to be helpful. So those are some of the medications that are out there. But again, the best antidepressant is the one that works for you. And in order to get to the one that works for you, it's really important to be very open and forthcoming about all of the symptoms of depression that you're experiencing, as well as past medications that you've tried, and if they helped or made some certain symptoms worse, if there were side effects, and then using that personalized data that's collected, the doctor can make an informed decision. I will say there have been, case reports, and when I first got into this field, almost 20 years ago now at this point, there was a lot of discussion about antidepressants and the need for more systematic study, because there was some concern, well, maybe it'll make motor functioning worse, maybe it'll make cognition worse, maybe there will be an adverse interaction with other medications that the individual needs to take. Unfortunately, as more research has taken place over time, while everybody is different and some people will experience more side effects than others, in general, these medications are really safe. And they tend to not worsen cognition. They don't worsen, motor effects most of the time. And there's typically not, while there's some precautions that folks need to take, there's typically not drug-drug interaction. Sometimes you have to be a little bit more careful if you're taking an MAOB inhibitor. Just look out for the interaction there. But apart from that, they're pretty well tolerated. So antidepressants are safe and they can be really helpful for many people. I actually study a non-pharmacological intervention called cognitive behavioral therapy, which is just a type of talk therapy. And it addresses a lot of what we were discussing earlier in terms of coping skills, helping people to learn healthier habits that they can utilize to manage their reactions to the understandable stressors and challenges that they're facing day in and day out. So some cognitive behavioral therapy techniques would be things like daily goal setting, working to very systematically and appropriately, increase involvement in meaningful and pleasurable and social activities, maybe learning some mindfulness or some relaxation strategies that an individual can use in order to slow down their breathing, to come back to the here and now and focus on one's breath. And then also, really importantly, really stopping to pause and reflect on what we're saying to ourselves, because the reality is we are constantly talking to ourselves. I know I constantly talk to myself all the time. We're constantly making meaning and interpreting what's going on around us. And oftentimes what we say can be kind of harmful and kind of negative. We can be pretty hard on ourselves. Most of the time, we would not speak to our loved ones under ordinary circumstances in the way we may speak to ourselves. So being able to pause and reflect on what we're saying, how we're interpreting what's going on around us and what's going on in our world, and kind of pressing pause on some of those really extreme negative thoughts that are going to slow us down and impede healthy coping efforts, and sort of rewind them and try to replay those thoughts in a more balanced, more compassionate way can be incredibly helpful. And the research shows that cognitive behavioral therapy can really lead to significant improvements in depression, in anxiety, in quality of life, and also in physical functioning and physical health. And I think that's because of the point that we were addressing earlier. If an individual can feel less depressed, they're going to be more proactive in their self-care. They're going to take their meds on time. They're going to exercise. They're going to do PT and OT. They're going to engage with the community. And that's going to help physical functioning as well as emotional functioning and mental health.
Yeah, thank you. That's great. For those of you interested, we will talk a little bit about how to find different types of therapists later on the call. So if that's something that you're interested in, we'll talk about that. Can you tell us just a little bit about how long typical CBT treatment is? I know it's not something, people can expect to go in and, oh, I got it, Tuesday, I'm all good. Like what is the expectation for people?
Yeah, so there's, and that's a really good point for medications as well. We don't have the magic wands. We have a lot of excellent skills and strategies and suggestions that we can share, but it's not the magic eraser. So as far as an antidepressant goes, let me start there since I was talking about the pharmacological treatments first. Unfortunately, taking a Zoloft is not like taking an Advil. You take an Advil and the headache is probably going to disappear, maybe after 2 tabs and 2 hours in a glass of water. With antidepressant medications, they need to build up in your system and get to a therapeutic level. And it can usually take up to 6 weeks in order to feel initial effects. And then people will continue to feel better and better as the dosage continues to be monitored and optimized over time. And that's really important with antidepressant medications, is making sure that you're on the right dosage. Oftentimes, especially if the antidepressant is prescribed, let's say by a family doctor who doesn't have a lot of specialized expertise in either depression or Parkinson's, the dosage tends to be too low. So people think, oh, well, this is not helping me, but it's really the dosage needs to be brought up to the therapeutic level. So that's always an important thing to consider. But it takes about 6 weeks to start to feel
Okay, I just
initial
want to
effects.
talk about that piece of it really quickly, because I do think that some people, will take it and it's not working. So what is the expectation of what they're going to feel? What are some maybe things to look out for that are a good sign that it's not working? Or yes, it's not a fun process to go through getting to that therapeutic level, but hang in there. Like, what are some good things to be looking for?
So if we take that 6-week period of time that I just outlined as an estimate, we want to kind of break that down maybe into 2-week intervals. So for the first 2 weeks, you're probably not going to notice much of a change, but right about 14 days, maybe if a medication's working, you're going to start to notice a mild or modest improvement. So maybe if the intensity of your depression, let's say, was an 8 out of 10, well, now maybe it's a 6 out of 10. So not a huge change, but it's starting to trend in the right direction. And then maybe by 4 weeks, you're down to like a 5 out of 10 or a 4 out of 10. And by 6 to 8 weeks, now maybe you're at a 2 out of 10 because it's really helping and it's really kicking in. So you're sort of gradually moving in the right direction. There should be a little bit of symptom relief, but it's probably realistically going to be minimal the first 2 to 4 weeks, and then you'll start to see bigger changes after that. The other thing that's important to keep in mind is sometimes those first couple of weeks, you may have more side effects as your body is getting used to the medication, but the side effects will go away as your body adjusts. So in the beginning, sometimes people get very frustrated because they have side effects and they're not experiencing a ton of benefits. So like, oh, I'm going to throw this bottle out the window because it's not doing anything for me. But we have to remember is that with time, the side effects will get less and less, and the therapeutic benefit will get more and more. If you don't notice that trend after, let's say, 4 weeks, if you're not starting to notice some improvement, then it either means the dose has to be increased sooner rather than later, or the doctor has to consider changing the medication. But it really is, it's a slow journey, those first 2, 4, 6 weeks, but then you should start to feel some effect.
Great.
As far as cognitive therapy goes, for all of the studies that I've done, and I have done 3 fairly large randomized controlled trials to date, as well as a couple of smaller treatment development pilot studies, we studied about a 3-month course of therapy. So individuals receiving counseling that focused on the principles that I just outlined, improving behaviors, pausing thoughts, learning meditation and relaxation, improving healthy sleep habits. So about, I'd say, 10 to 14 sessions would be considered like the acute dose of the psychotherapy, but then most people find it beneficial to continue to receive care over time, maybe every other week instead of initially weekly, and then sometimes once a month in booster sessions. But again, we're talking about, weeks and a few months of practice. And what's so important about therapy is not just learning the skills and the techniques and maybe new and innovative ways of thinking and behaving in session, but taking what you learn and practicing it day in and day out, implementing those changes into your daily life. That's really what makes a big difference over time. And I've shared this analogy before. So if you've heard me give other talks, you've heard me, use this analogy, but I think it's an important one. If you go to the pharmacy and you fill your prescription for carbidopa levodopa and you come home and you stick the pill bottle in the cabinet and you just look at it, you're probably going to be pretty symptomatic. You have to take those Parkinson's meds on time every time in order to have physical benefit and physical relief. Same thing goes with any skill or strategy that an individual might learn under the umbrella of CBT or another type of non-pharmacological intervention. If you don't take those skills and figure out a way to implement them day in and day out into your daily life, just knowing them isn't going to be enough in order to be truly helpful for you.
Great. What role have you seen exercise and food play in depression and in working with depression?
Huge. So exercise is incredible, not just for improving motor control in Parkinson's, but also with respect to enhancing mood. So when it comes to exercise, there are actually some very interesting studies that have been done in individuals without Parkinson's, where they've compared, what are the short and longer term impacts on mood for individuals who exercise, at that critical threshold of about 150 minutes a week of cardio, compared to those who don't exercise and they start antidepressant medication, and exercise did the same or better than the antidepressant medications in terms of alleviating depression and anxiety over time. For that reason, and because of what I've just learned, from working with people over the past 2 decades, not only in research, but in my clinical practice, exercise is a key component to the cognitive behavioral treatment package that I utilize in my programs. So like session 1, day 1, exercise is the first thing that we talk about. I really consider it the low-hanging fruit. If we can get people more engaged in exercise, any type of exercise that they find physically safe, that they're able to do. It doesn't have to be anything, so crazy or strenuous. If rock steady's too much, it could be yoga. It could be a walk around the block. It could be jumping on the exercise bike. But some exercise every day is foundational to the program that I run, in addition to setting other daily goals related to socialization, and, meaning and pleasure and reward. So that is key. And I definitely see the effects. The interesting thing with cognitive behavioral therapy, we're talking about like the timeline for medication effects to kick in, usually around 2 to 3 weeks is when you also find an initial improvement in mood in response to cognitive therapy. And it's, in my case, in my programs, it's because we're pushing exercise and becoming more active. And that's the quickest way to improve your mood. And there's definitely literature out there regarding nutrition as well, and the importance of probiotics and really eating, clean and green, and trying to limit a lot of the sugary processed foods, the refined carbs. There have been some studies that have shown, more mood enhancing effects from like a Mediterranean or Mind type diet that really emphasizes fruits and vegetables and healthy fats, lean proteins like fish and chicken versus the higher fat meats like steak and hamburger. Nuts and seeds are really good. So there can be maybe even simple nutritional changes that people make on a regular basis that can really improve their overall quality of life, as well as their mood and their Parkinson's motor control over time.
Right. Okay, let's move to the same questions around anxiety. What sort of medications are used to treat anxiety? Are there anti-anxiety and, antidepressants that are used together commonly? And what are some non-pharmacological ways to help with anxiety?
So starting on the medication side again, I think it's really important to mention that antidepressants, most of them, also have really nice anti-anxiety effects. And sometimes if we're using an antidepressant for the primary treatment of anxiety, and again, there's a lot of individual variability here. So a lot of this will be determined by a given person's, unique symptom profile. But sometimes we might use antidepressants in lower doses if we are using them for the primary indication of anxiety. Sometimes we have to use them in higher doses. It depends on the medication, it depends on the person. But that's actually like the SSRIs, like the Prozacs and the Zolofts and the Celexa and Lexapro. I would consider those to be the first line intervention pharmacologically for anxiety. There are other shorter acting medications that fall under the category anti-anxiety, or sometimes we'll call them tranquilizers or benzodiazepines, medications you may be familiar with like Xanax or Klonopin. Those medications, kind of like that Advil example, they'll kick in really quickly when you take them. And you may get a very short period of anxiety reduction, but the medication is in and out of your system very quickly. So whereas the antidepressants, they build up in your system and you have therapeutic levels and they kind of maintain you, at a steady level for 24 hours, most of these anti-anxiety medications or benzodiazepines, they're very, very fast acting. So in and out of your system in only a couple of hours. So if people are just using like a Xanax type medication for symptom relief, they may find that they're taking it several times a day because the half-life is so short, and they're metabolizing that medication so very quickly. And there is a place for them. And sometimes people will use the anti-anxiety and antidepressant medications together. The one word of caution that I have to offer is that especially in the context of Parkinson's disease, we have to be mindful that anti-anxiety medications, the benzodiazepines, the Xanax, the Klonopins, can sometimes increase risk for fall. As people get older and as they become less steady on their feet, whereas the antidepressant medications that may be used for anxiety control don't have that same type of side effect associated with them. So, and again, the anti-anxieties, the benzodiazepines, they're safe as long as you're taking them as prescribed by your doctor and following guidance and reporting any difficulties or side effects, you're going to be okay. I'm just cautioning that we don't want to overuse because there is that risk of potentially increasing falls, which we don't want to happen to anybody, certainly not anybody living with Parkinson's.
Yeah, and also another important thing to talk about is just if you're taking any of these, especially something like Xanax or that, like you don't want to go off of it without your without talking to your doctor. Anytime you don't want to say, hey, I'm done with it, because there can be a lot of repercussions for that. So definitely work with your doctor on.
Exactly. We don't want to shock our system. Just like you're going to start low and slow. If you're beginning a medication, you're going to go off a medication slowly if you decide that it's not really working for you or you're not noticing the intended effects, because again, we don't want to do any harm. And sometimes if we stop something abruptly, we're going to feel a lot worse. And there can be better ways to approach changing our meds than just an abrupt discontinuation. And as far as non-pharmacological for anxiety, a lot of the strategies, pretty much all of the strategies that I talked about for depression are also helpful for anxiety, but they would be applied in a slightly different way. So if I was working with somebody with primary anxiety, I would probably spend more of my time focusing on the relaxation training and the breathing and mindfulness and yoga, maybe earlier in treatment. Whereas with depression, I would layer in those strategies and techniques a little bit later on in the course of therapy. That's really important. And also the content of our thoughts differs. So there are certain types of thoughts that, trigger depression. There are certain types of thoughts that trigger anxiety. So cognitive behavioral therapy for anxiety would really focus on the content of those anxiety provoking thoughts, which is usually a little bit different than the content of thoughts that lead to depression. So usually thoughts that lead to depression, and again, this is an overgeneralization, but tend to sort of fall in the categories of negative thoughts about the self, about the world, about the future. Anxiety-provoking thoughts tend to involve a lot of uncertainty, a lot of fear, a lot of what if.
Okay, interesting. And then I got this question that I just want to talk about. The person said that her husband has PD, but they were told he had had depression for a really long time, and told that unlike other people with depression who might take meds for 6 months or a couple of years, that people with PD don't get off their antidepressants. They're on them for life. That was sort of what their doctor said. Is that typical for you to see when you see patients, that they end up, if they do have depression related to, it's a big non-motor symptom for them, that they end up staying on forever, kind of like their Simet?
So not necessarily. And again, everybody is different. And I think this goes for people with or without Parkinson's disease. Some people, in order, once you kind of get to a place where your mood's improved, you want to keep doing whatever it was that you were doing that got you there. So if that's therapy or meds or combination, oftentimes I will encourage my clients that I work with, Parkinson's or not, if this is working, I want you to stay on it because it's helping you. So there's no reason to go off of the antidepressant because it's not harmful, it's not addictive, it's not going to, predispose you to other risks or side effects. So I'm not so sure that's just a Parkinson's clinical point, but in general, it's good clinical practice that once we help an individual to feel well, we want to keep you well. So Parkinson's or not, as a general rule of thumb, once we have an individual close to remission, meaning very few symptoms, we usually say stay on your current regimen at least 12 more months before we even talk about beginning to back it up a bit, because it's working. Now, because of the stressors and challenges unique to Parkinson's, that an individual without Parkinson's may not face, there may be additional mood vulnerability there. So individuals with Parkinson's may need to be that much more considerate about the unintended consequences of stopping an antidepressant medication once that they're feeling better, but it's absolutely not a must or a mandate. So yes, you're probably going to be taking Sinemet or something like it for dopaminergic replacement, for your journey with Parkinson's, but no, absolutely not. It's not a universal mandate that a person with Parkinson's must stay on antidepressants forever in order to keep their mood under control. It's really case by case.
Yeah. And I feel like we hear a lot of people that say they got on the medication because they were just in a really bad spot, and they were in such a bad spot that they weren't able to do the non-pharmacological things that can help them. So that once they had that, and then they started a habit of exercising and a habit of eating differently, then they could slowly go off. But they had those other things too that are sort of aligned with minimizing their depression and anxiety.
Yeah, there has to be something in place for
right.
maintenance of your gains and for prevention. And I see similar trend, like oftentimes people will need to start medication in order to feel well enough, in order to learn the skills and learn the techniques. And then once they learn the techniques, they can roll with them. But some people need to continue to practice those skills day in and day out, along with continuing to take medication, because that's the package that works for them. And others might not need to or might not choose to, but it's very individual, and it's really based on your unique pattern of response.
Great. So I know people are going to ask, and some people have already asked, but if you're taking patients, and I know you're not taking any new patients right now, but how can people look for a good therapist, somebody who understands Parkinson's and understands all of the different non-motor symptoms that go along with it, so that they can help them have a better quality of life? What are some steps people can take?
So any good therapist will educate themselves about Parkinson's. They will read, they will ask you, give me resources. I want to learn from you. There are, certainly there's some of us out there that know a lot about Parkinson's, but most therapists, most mental health professionals don't. That being said, there are sort of subgroups of mental health professionals and counselors that may have experience in what we call behavioral medicine or health psychology. So they might not work with Parkinson's specifically, but they have a lot of specialized training and expertise in working with individuals with other types of chronic medical conditions. So if you're looking up psychologists or social workers, in your local area, and you're reading about their backgrounds, if they say that they have any expertise or training working with individuals with chronic medical conditions, or they mention health psychology or behavioral medicine, then that's kind of a good sign that suggests, hey, maybe I'll make a phone call and learn a little bit more about whether or not this could be a match. Each state also has there could be some exceptions, but in general, each state has their own psychological association. So in New Jersey, we have something called the New Jersey Psychological Association, and those associations tend to keep a referral directory of all the licensed mental health providers in their area. And then you can search to see, okay, who has expertise in medical conditions, who lives in my county, who takes Medicare, and they're usually vetted before they're posted on the website for the local psychological association. So that's like a hidden little secret. So I would consult with your state's psychological board, and they're a really good source of names and resources. There's also a website called Psychology Today, where again, you can search and filter based on area of expertise. And again, people tend to be pretty happy with some of the referrals that they connect with on that platform. And there's also an association of behavioral and cognitive therapists. It's called ABCT, and they maintain a national directory, as does the American Psychological Association, the APA. So those would be some good resources to get started with. And of course, if your movement disorder specialist or Parkinson's doctor has local mental health professionals that they work with, that would be the low-hanging fruit that I would start with. I'd ask for a personal recommendation. And then if you can't get a personal recommendation from your neurologist or from your family doctor, then I would go to some of these outside resources that I just mentioned.
Great, thank you. And I know we only have a couple minutes left, but just really quickly wanted to talk a little bit about telemedicine, because I know that right now your practice is almost entirely telemedicine. Can you talk to people a little bit about how does therapy work over telemedicine? Is it just as effective? What are the, what should they look out for? Is it something that they can really begin to see somebody new over telemedicine? That kind of thing.
So and Mel knows this, I have been a huge advocate of telemedicine even long before the pandemic started. And I've done a lot of research in this area. And just, super briefly, my research has shown that whether we administer, cognitive therapy like in person sitting in my office versus on a Zoom screen, like we're all speaking right now, versus over the phone, even without that video capability, the results are almost identical. Like we couldn't make up data that looked more similar. So there's no efficacy or effectiveness that seems to be lost by receiving treatment on a remote platform. That being said, it's not for everybody. So it really depends on your needs and your preferences and your comfort level. There are some people that really just prefer being in person and being in the room, and that's fine. There are others where it's a major convenience to not have to travel an hour and a half each way, to sit in a therapist's office, and they're perfectly comfortable, on the Zoom screen. So I think as long as you're working with a skilled and competent clinician that is willing to learn and grow with you, whether that therapy is happening on the screen or over the phone or in the office, doesn't really matter. What matters is that you feel comfortable with the way in which the treatment is being implemented, and even more importantly, that you feel comfortable with the person that you're sitting across from.
Yeah, I think it's so important that that you made that note that a lot of therapists are open to learning from you. So you might be in an area of in your state where there aren't people who specialize in Parkinson's or anything like that, but therapists tend to be a very proactive, learned bunch, and they're willing to learn, and they want, if somebody comes to them, they want to learn what Parkinson's is about. They want to be able to use that with other people. So don't be afraid to ask those questions of your therapist and say, this is my situation. Do you have any experience with it? And if not, and they're, that's the person that's local to you, are you willing to? And how can I help you learn more about Parkinson's? So I think that's a really important point to make.
And any skilled therapist would capitalize on that opportunity. And if they don't embrace the chance, then you need to look someplace else.
Absolutely. Absolutely. Great. Well, thank you so much. I know that I could talk to you forever about this topic, and maybe we'll get to do so again. And I appreciate everybody. We got to many of the questions that were asked. I know we didn't get to everything, but hopefully we were provided some usefulness to all of you out there. If you have any questions, feel free to email us at blog@dpf.org. I would love to thank our sponsors, our peak partners, Amneal and Adamas, Lundbeck, and Synovian. They make it possible for us to host these events and to make them free to everybody. So thank you so much for that. And thank you all for showing up today as a big group. And we're really, really grateful to have you.
It's my pleasure to be with you guys this afternoon.
Thanks so much.